The purpose of the initial consultation is obviously a patient has determined that they have some fertility problem. Either it's been determined by their gynecologist, their internist, their acupuncturist, or the patient themselves. And so they come in and for an evaluation. And usually what's appropriate is if someone below the age of 35 has been trying for about a year on their own, or if someone is above the age of 35, if they've tried for about 6 months, and that would be enough time for them to come in for an evaluation. On the initial consultation, what we gather is first their age, which is a very critical piece of information because we want to know, if someone who's 20 has a different pregnancy rate than someone who's 30 or 40. If someone has been pregnant multiple times and had babies and now has secondary infertility, that is totally different than someone who's been trying for a very long time and has never been pregnant. We have to understand there's many different permutations of this. We ask about family history, age of mother's menopause. Someone is in my office and they're 40 and their mother had menopause when they were 41. That is a strong family history for early menopause. We want to know. If her mom or her sister had fertility problems and miscarriages, that is significant information. Or endometriosis, a condition where the endometrial tissue that people shed every month is now found inside the abdomen or other places, which can cause scar tissue and painful periods. That is an important information. So bottom line is to elicit the history of the patient to kind of be able to tailor the appropriate treatment for them. So getting that information is very important so that I can enter the information into the computer, formulate a plan, and then that way, from that point on, the office staff and I know what we have to do for you, as opposed to someone else. Then the next step is for us to go over the options of treatments, and we have low-tech treatments, and I guess we call them high-tech treatments, or assisted reproductive technology. So the initial consult involves really determining what are the issues we have to deal with, what are the further tests we have to do, and which direction do I think is the best way to go. But that direction that I think is best to go has a lot to do with also the patient's desires. So we have to blend in what is their desires, what is their financial situation, can they afford a certain treatment or not, is that best for them or not? Does their religious beliefs allow those treatments to be done? Are they comfortable with those treatments? So it's not like I say, we do this and that's it. We have to blend all those in to be able to come up with a plan. Now the plan is most often to lay out the tests that we need to do. So the initial consultation, we say we need you to call with the first day of your menses. We need to see you within the first 2-3 days of your menses. And then we gather the information about the hormone tests, the ultrasound, the x-ray. We add the information from the male partner as far as the sperm results. We put all that together in a follow-up discussion. And all this is explained to the patient on the first initial consult. So when you leave the office, you kind of have an idea of what are the odds of success, what are the potential treatments that could be available, their success rates, their costs, and what is our plan to determine what treatment is best. So when the initial consult is over, a plan is formulated, and then we see the patient when they call with their period.